Hope that can work out too well. Hi, guys. Give it a couple more minutes and we'll get started. I'm at Remo with Mike, Rob,
Andy,
and Dean.
who also didn't bring cookies?
And nobody brought cookies. I'm not sure why I'm here.
Given I'm bringing cookies, so therefore, yeah, we have our cookies.
So,
Or you can pull that table this way, we'll have our U arrangement just.
we can do that. So we're gonna try and do today is we'll have sort of the advisory committee meeting and then no dead space and Rob will take over with the Remac meeting. Really not a whole lot to say for the advisory committee meeting, so this will probably go pretty quick. Just trying to sort out where we're here. All right, why don't we give it one more minute and then we'll get started.
Hey Doc,
Yeah,
it's hard to hear you when you're faced to your left, but we can hear you pretty good when you're speaking right into the screen.
okay,
Like that's good.
okay, sounds good. This is actually Tim's computer, not mine, that had problems last time.
Yeah, no, he's got to work on that.
You got Tim's? Huh? Got everybody?
I'll just.
Okay. All right, why don't we get started? Can we have somebody to approve the minutes from last meeting? Anybody?
I can make that motion.
Okay, and Sam, it looks like you're seconding it, so, okay, minutes are approved. All right, things to talk about. Dr. Daly would like some more people to sign up for bloodborne, bloodborne, blood transfusion. Blood transfusion protocols for us. So please give Mike a call if you're interested at all. We're trying to get it so it is at least coordinated. It's a scarce resource and it's not appropriate to be on every agency. So give Mike a call. I'll be happy to hear from you anytime. He said call him at 3 a.m. It's fine. Okay.
You have two, and right now.
Okay. Two phone numbers. 518 573. Who is that? Okay, you just kind of turned on your audio. Who are you?
Identify yourself.
Ends in 2477.
Daniel. Got it.
Okay, where's the other one? I'm not seeing it on the screen.
I'm here. It's Bill Fisher. I'm at 4245.
Okay, that's for sure. Okay, thank you.
369 4245. Yep.
Okay, moving along. Trying to sort through. Tim didn't separate the minutes here, so it's a little bit confusing. Where's your?
Those are the two items
And where were the new courses?
on the front page.
Okay, sorry for the confusion, guys. We'll make this work better next time. All right. Training. Let's see. I'm trying to see who's here. Bob, anything from Hudson Valley? You're here. Okay, I don't see Bob. Jonathan from Cobleskill?
Nothing new right now. Next semester, spring semester, we'll have another EMT and refresher class starting.
Okay. All right. Remo
Mr.
has
Phillips just joined the meeting.
okay. Bob Phillips, anything from Hudson Valley?
Nothing new from our last meeting. We have 2 paramedic cohorts in progress. We have 2 EMT originals and an EMT refresher in progress. And I think somewhere on the agenda mentions the HVCC Remo CLI course coming up in November.
Right, that'll be there. It starts at 11:14.
Yep.
Gilderman has a EMT starting on 10:08 and a refresher starting on 11:12, and Mohawk has an EMT original starting on 10:21. Those are the only ones I know about. Anybody have any others that they're aware of? Okay. Some new business. Antibiotic use. Anybody use antibiotics yet for open bone, long bone fractures? Okay, I guess not. What's that?
So Don, that is.
You have to.
Sorry, so Anna,
You and.
oh,
Do you want me to see if I can run a report on it?
Yeah, Beth, if you could make sure we do that. And also, anytime we do have an antibiotic use, we're going to try to follow those cases with the folks from trauma. Because most of those cases should end up at the med. Or if they're in Arams, they should end up at Bassett. So we need to make sure that those get followed closely.
I know of one case up north where it was used, and it was for like an open facial fracture or something, but it wasn't anything to do with Gilliland. One of our medics up north, he works up north as well, and I know it was used up there. So I don't want to talk too much about it because it's not us, but.
No, I certainly appreciate that, Jay. Was that in up north in Remo or up north past Remo?
In Remo. I can tell you the medic was, I think it was Matt G.
Okay, if you would do me a favor and just pass a note along to that service and ask them to send us the specifics of the case so we can track it.
thank you.
Thank you.
Doctors, would you like that report monthly?
Sure.
I would say,
It's not gonna happen that often.
Yeah. Beth, let's discuss the best pathway for that offline, and work on that with Terry Snyder and Danielle and the team from AMC Trauma.
Okay,
Beth, the other is you're gonna need a contact at Bassett for the trauma coordinator out there.
actually just made contact with her last week. I have the trauma nurse information.
Okay, great. All right, otherwise I'd get it for you. Okay, thank you. Anybody have any question on the DOH new policies? I think Tim just sent them out to everybody. If you haven't received them, you will receive them shortly. Okay. Well, truthfully, that's all I have. Quick.
We have some time, maybe we'll talk more about it in the Remac, but as I think a lot of people know that the governor signed into law the blood administration and the treatment place. I know that we've talked a bit about, theoretical issues with counties and stuff. Have we thought about that much more? And we have a plan for implementation or any more thoughts on blood administration as well as place? Yeah, I haven't really dug into the law to exactly what she signed in that. But are we gonna leave that up to the agencies or the state? Is the state gonna develop a protocol? Is the Remac gonna develop a protocol? Or is the CMAC gonna take a lead on that? With medical control and, telemedicine and things like that, it's not law. So I'm just wondering the timelines on both of them and if there's gonna be protocols in place or if there's gonna be working, with just things like that.
So let me hit you with blood specifically first. So the blood regs for ground will be in process. There are a few of us that were asked to participate in terms of building those. In the meantime, the last couple of meetings, I've asked for participation from regional agencies who might be interested in assisting us with developing a regional policy, both for ARMS and for Remo. You know, obviously, this is not going to be a resource we're going to be able to have with every agency. There will be a few, and we're going to have to come up with a specific list of requirements for that, and then some best practices. So there's a whole bunch of different things that will come in terms of putting this all in place and making it as effective as possible.
We're working on that now. Do you need any assistance, or do you have an idea of a timeline kind of thing?
No idea on a timeline right now, because the state regs are going to be an important part of that. And those travel at the speed of the state. However, they did a great job with the air medical stuff that they worked on so far. So we'll just have to see what else comes for us. In terms of best practices, we are going to refer, I think, a lot to LifeNet, who have done an excellent job in terms of developing some best practices there, as well as reflecting on how they're doing things in San Antonio in particular. There are a couple of great examples in Massachusetts. One that's a really good example of how to do a program. One is a good example of probably how not to do a program. So the small group that we put together will work on those. We are not going to ask people to do their own systems of blood administration, blood storage, and everything. We'll push out best practices that people can then sign on to doing once they are approved by the Remac and the RTAC for participation, because we need to make sure that both are completely on board. What we had talked about in the past is making sure that nobody is independently going and having discussions with blood banks, because that is something that will basically ultimately deep six the program if the blood banks are not are active participants in this. So that will be done by that committee as the sole source of communication.
Hi, Green. What's the thoughts on treat and place?
I can speak to that.
Okay,
If you
go ahead,
read
Beth.
if you read the legislation, there's at the very bottom of it, it says subject to matching funds from Medicare. So at this point, there has to be a state plan amendment or SAP that gets submitted to Medicare for matching funds. So Rich Brandt spoke at the meeting and said that that would be going in. So we're still waiting for the other portion of that to happen.
With the treat and place?
For the tip and tad.
Yep. Yes, for that, Jay.
All right, so is there any thought that there's not gonna be matching? Or is that pretty much gonna happen?
He seemed to think it was going to happen, but he had no timeline. He said there is one state amendment plan that he's had in with them for 3 years.
But they will have. Well, they can't not allow.
But we need to be ready to go with a protocol, what's appropriate to treat, what's allowed to treat. We have to be ready to go with it.
So Paul, you're asking for protocol, what's appropriate to leave at home, what's not?
Just like we did for ET3. Like we gotta do it for this too.
Agreed. We should have protocols and things set and actually have a plan in place before
Right.
we wait for the funding.
So the thing is, like, a lot of, I mean, I think that it'd be best to have a regional protocol. I mean, a lot of the agencies that used UCM, or maybe prior to that, it had Landmark, had their own. So, but I think the law is different now than we were doing the RMA kind of workaround thing. And I think it would help agencies if we had some guidance in the form of a protocol for that.
Well, we can take a look at the ET3 protocol and see how it would fit, probably.
The ET3 procedure.
Mhm.
Out of the ET3 protocol, regions may develop procedures that are specific to local conditions. That's what these.
We didn't hear it.
What's that?
We couldn't hear Dr. Daly.
It's a procedure, not a protocol.
Hmm.
Yeah.
Did, forgive my ignorance, but did, Remo have an ET3 procedure?
Yes.
We
Yes.
believe.
All right. Did they have designated, alternate destinations?
You're going top up.
There, I remember at one point there was the discussion of the alternate destinations, but that never came to fruition. They never actually rolled that out in the region. Right, Carol? Am I speaking out of turn? Because you're agency.
Yeah, can you guys hear me now?
Yeah, we can hear you. Go
Okay,
ahead.
I'm sorry. I got a new computer and it's been chaos for the past week. Yeah, we worked on the problem with alternative destinations is we met with the urgent care centers in the region. St. Peter's really wasn't interested in participating with us. Ellis worked out pretty well for the Clifton Park folks. And then we were going to work with the Albany Med folks. And the problem with the Albany Med, the way we had it set up was that we were going to have a telehealth visit at the time of the call, and the doctor from the telehealth was going to communicate to the urgent care center to kind of describe the patient and get the doctor at the urgent care to accept the patient. The problem we had with Albany Med was there was no central number, there was no number you could call to get a specific urgent care. Like you couldn't call the urgent care in Brunswick and get a doctor at the urgent care in Brunswick to pick up the phone. So they were trying to work on a phone system that would enable that to happen. It really never happened, and ET3 kind of went sideways and fell apart. Right now, there's really nothing to stop us from doing treat in place because you can negotiate with any of your insurance providers to get them to cover it because the Medicaid is just for Medicaid enrollees. So we can certainly work with other payers, and some, I believe, do cover some of the treat in place. So we should probably work on taking the ET3 guidelines and, you know, revisiting those and seeing if we can buff those up a bit.
Okay, sounds like a plan. And maybe we can have Tim stepped out, but maybe Tim can send those out to everyone. So the next meeting we have, we can go
Yeah,
over.
and I'm not even sure if Tim had them or if it was because we had a work group back with the ET3 agencies. So I'm not sure how much involvement Remo had. I can't honestly remember, but it was Clifton Park, Mohawk, Colony, and Empire. So we kind of all got together and came up with a plan. I'm not sure who's got what where, but we can try to figure something out.
Do you have, Carol?
I'm not sure if I do, but I can certainly look. It's been a while.
Carol, I have some documents that I'm finding, but I would have to dig through them and see what they might have.
Okay. All right, I'll have to look too. And
Yeah,
as
each
for
agency pretty much built up their own policy
Yeah.
that's roughly similar. There wasn't a
right,
Remac-
each agency kind of did their own thing to a point, but we kind of worked together. Yeah, but there was no regional real plan because it wasn't really a regional thing at the time. And as for the state plan amendment, it has to be submitted by the end of the year, I believe, and they'll act on it after that. So the federal government will. So like Don said, it's the speed of government, and it'll get there as fast as it gets there, I guess. The good thing is it's designed to save money, so they'll probably be very receptive to it. The other plan that he's been waiting 4 years for is probably going to cost them more money than they want to spend. So that's probably why they're dragging their feet. So we do have hope that it will progress.
Okay. Thank you, Carol. Well, if you can see what you have, maybe work with Beth.
Sure.
Yeah, do you have it? Tim?
Does Tim have it?
Tim, you saw it?
I sent it to, I just sent Beth a bunch of documents, sort through them, we'll find out what's relevant still in there, and we'll distribute to the group.
Okay, sounds like a plan.
The treat in place procedure was something that was approved by the Remac 4 years ago.
That's a while ago.
Whenever we were active in that.
Okay.
All right, we'll bring it up at the next meeting. And see what we can do with that, so we have something. Any other questions on that?
I want to go back to blood.
All right, Dean wants to go back to blood.
So we kind of,
Dean, come on over this way.
You kind of go lumped together the transfusion service. Can you hear me now?
Yeah, we hear you.
We lumped together the blood transfusion service and the carrying of blood on the ambulance or having a program, countywide program. But how do the two really relate? And those are two separate and distinct programs, correct?
So,
There we go.
well, Dean brings up an excellent point. So there's a bunch of different things. There's existing regulation around the ambulance transfusion service. There's DOH interpretation of the existing regulations around transfusion service, which actually has little to do with the regulations themselves. Then there's the regulations that will be in place over the ability to carry and initiate transfusion. With the air ambulance, they were sort of combined into one, which made life much, much easier. Because as soon as ground ambulances are allowed to initiate transfusion, we should be able to include carry transfusions that have been initiated in hospitals. There was some question of interpretation in that because it's the Article 28, Article 30 stuff in terms of an inter-facility move. But hopefully we will be able to smooth all of that stuff out and make it easier for people just to carry a transfusion from one hospital to another when it's the right thing for a patient. So that's my distinct hope. And frankly, the department has been really active in terms of working to make these things make as much sense as possible. So I actually have great optimism.
Part A and part B to the program?
Just blood. Just blood.
So we either
Take it and then, but we're not, that doesn't mean we're not to carry it.
Right.
Because, okay.
Right. That would be my hope. That would be my distinct hope. Because there are a lot more times where interfacility transfers with blood products hanging will be exactly the right thing to do. But having the accessibility to a low titer whole blood transfusion from an EMS provider initiating that is going to have nothing to do with the care of that patient. So, I mean, I think of, the critical OB patient being moved from one place to another that had gone in on their own into the hospital, needs a transfusion on the way from one place that could just be done.
which is initiated already.
Exactly. Exactly. So my hope is that we can get some reality to this, and I think we can get there.
Oh, do you have anything to add?
Not really on that. I mean, there's still a lot of stuff going on in this place for everyone. But I'm involved with this.
Okay. Well, wait to see what DOH has to say.
Make sure that the DOH knows.
Yes, Alex made no comment. There is a pretty good procedure for ET3, which Tim has. He's sending it out to Beth. We'll bring it up at the next meeting, and it actually looks pretty reasonable. Could easily be adapted to what we need to do. Okay, any other questions?
Don, this is Art. I had given Tim kind of like a draft of a proposal for like a medical advisory for hospital notifications because several of the hospitals are reporting very limited information and vague complaints, no vital signs with patient conditions that are with the Pulsera notifications. It's something that actually I worked with Dr. Cushman with to kind of work up. I don't know if Tim can put it up or not, but it's just really, really some basic information. It's not a comprehensive briefing. It's just really, something to be ready for the patient and have the resources or room available.
Okay. Hey, Tim. Tim walked away again. Tim. Could you end up in this direction for a minute, please?
I'm trying to find if I have it readily available.
So Art basically sent some information to you that he suggests folks who are sending in Pulsar reports actually have put in their Pulsar report because they're missing a whole bunch of critical information. Do you have anything with that, or do you want to put it up?
I distributed what I got to the group. Let me see if I still have it. I don't.
I can resend it to you.
Well, Tim's heading in the other direction.
To everybody.
Hang on. You guys do realize if you were all here, this would be much easier. Just trying.
You didn't bring any cookies, why should I come?
True.
Yeah, I mean, we've been getting stuff like, just like in the PZD the other day, it was, 7-year-old child struck by motor vehicle knee pain.
Hmm.
No vital signs. A couple weeks ago, it was a gunshot wound to the chest. No vital signs, didn't know if it was an arrest. And this goes with, it's even with the VHF radio with hospital notifications, triage is, had to ask like last known well, same thing with the strokes. But very limited information. And it seems whether it's from Columbia Memorial up to Glens Falls, Ellis, Saratoga, everybody is experiencing it.
Okay. Well, unfortunately, Tim can't put this up on the screen because he doesn't have that capability. But I can ask him to send it out to everybody. It's about one page long.
I'm just gonna ask a question here. Are you finding it's on cases where it's high acuity and the medic is
No,
really busy, or is it just?
no,
Okay. I just curious about that.
no,
So it's just being kind of lazy and not putting the information itself.
that is correct.
Okay. Well, the folks who are here from different agencies, if you could let your medics know they need to be a little more precise with their Pulsara information. And we can have Tim send this out to everybody.
I just resent it to Timmy and Beth.
Okay. All right. Anything else? Any other new business? All right. In that case, why don't we close the meeting and turn it over to Rob? Can I have a motion to end the advisory committee meeting? Come on, guys, somebody.
Motion to adjourn.
Okay, Sam made the motion to adjourn, and Dr. Daly seconded that motion.
And now onto something not completely different.
Okay.
So motion to approve our minutes from. Yeah, I think next time we should make a motion to approve both minutes. Motion to approve the Remac minutes from September. Okay, I've got multiple people waving at me now. Okay, disciplinary actions, a lot less than last time. David Eschelman, Lima, New York, certification suspended for 1 year, effective 9/12, $8,000 fine, and medical record reports required for the next 3 years. I haven't seen that one before. Tyler Fending, Lockport, New York, certification suspended for 1 year, effective 9/10, suspension stayed, assessed civil penalty of 2,000. Training, we already talked about these. Academic, us, we don't have reports because everyone is already here. Remsco, I was not at this Remsco last time. Were you at Remsco, anything exciting? Okay. None of us were at Remsco. Tim? You ran away again. Okay, we'll get back to that. CMAC?
So really not a whole lot for the park rangers. The austere protocols were basically approved. New York City had some changes in their protocols. Those were approved. There was a bit of a discussion about Nassau County again. Fortunately, everybody up here plays well in the sandbox. I guess down there they don't. So there was a concern with medical control and a Remac not being able to get quality improvement data because one of the hospitals was refusing to give it. As best as I make out reading the regs, it's recommended that the Remac can ask for medical control information from hospitals, but there's nothing that says they have to give it up. So,
But it's helpful when you want to.
well, yeah, absolutely. So that was a major discussion. Really, it wasn't that much else. We have a number of new CMAC members. A whole bunch of people were vetted, which was great. So we ended up having a problem with the quorum again. That's my report from CMAC.
For Remsco, we talked about train dates and EMS awards. Michael Preziosi from Clifton Park received New York State EMS Council's Excellence in EMS Quality and Safety Award. Second, yep, nothing like that. Okay. Yep. And anything, no report from Hawk?
No.
Agency updates, BLS modalities, Saratoga Harness Ambulance is adding BLS Epi, Narcan, and Albuterol. EPCRs, Otega Emergency Squad, State Elite Site, Shoreway Ambulance going to Zoll, Edmondson Fire District, State Elite, Niskuna Fire number 1, Zoll. We did this last month. Okay. Town of Hancock, State Elite, West Family, PPR, and Headwaters EMS Trauma Soft. Public access, Saratoga Regional YMCA.
Dr. McHugh?
Yes.
Okay. It's Art. With the State Elite software, that it doesn't meet their policy statement, have we like followed up with the people that have these programs that they need to get the PCR to the hospital?
I will follow up on that. So it doesn't connect to the hospital?
That's correct. It does not get to the hospital. There's no fax. They have to manually print it out and fax it.
Okay. McLean Companies update, St. John Lutheran Church, Safety Group 430, St. Mary's Church in Waterford, GE Vernova, Canajahara Youth Center, Paicho Hatora, Brunswick Veterinary Hospital. And that's it for PAD.
Can I add in a few here that got missed?
Okay.
For both the public access defibrillation, GE Vernova Schenectady, New York, US Power, an update, Canajahari Community Youth Center, original, Heichel Hatora, original, Brunswick Veterinary Hospital, original. For EPCR changes, West Sand Lake Volunteer Fire Company going to Cloud PCR. Hancock Ambulance wanted to go to State Elite, realized that they did not want to pay the extra to get the field and canceled at the last minute. And Headwaters EMS will be starting with Trauma Soft in November.
Yep.
Thank you.
Okay. Art, did you have anything else to add for your Pulsara? We already had that discussion. So please, if you're using Pulsara, which please use Pulsara, put usable information in it. If medics are test saturated, happy to pick up the phone and have us call us.
I have that document now if you want it up.
Which document?
The Pulsara, standardized Pulsara use throughout the region proposal.
Sure.
Is that the one you were speaking of, Art?
Yes, that's it. I mean, it's not, it's not a lot of information that, again, that we're looking for. You can get a full report, when people come there, but it just, some really important information that, again, we can be ready for the patient on the hospital side. So.
Okay, thanks, Beth. Art, 250 ml bags for restocks.
Yeah, I mean, there was a request from Robbie McHugh from Colony EMS that they were going to go to that. And, kind of threw that to Dr. Daly, and as long as it's part of the restocking, we have the ability to do that, but it wasn't part of the restocking program. So that's why we turfed it over here.
Make the motion to add it to the restocking.
Yep. And if nobody heard that, that was Mike making a motion to add it. Can I get a second? I'll get a second from Don. Anyone opposed? Okay.
The one thing I would like to add with that change in the restocking agreement is, something that was our concern when we initially went to, the two.
We can't hear you, Doc.
Get my steps in today at least. So the concern that we had when we originally went to the 250 bag for D10 was that it would potentially be confused with other things. My recommendation to agencies would be that they come up with an engineering control specific to each agency, so that we don't give saline by mistake to patients who need sugar, or sugar by mistake to patients who just need.
We can hardly hear you.
Why?
I have no idea.
Why? Can you hear me now?
Yes.
Yeah, so can Verizon.
Thanks, Art. All right, so, the concern was that we initially had set it up so that we had 100 bags of saline, 250 bags of sugar, and 1,000 bags of saline. Now we have two different 250 bags. My suggestion to each agency would be to come up with some type of color coding or tape, something that will identify those bags so we don't end up giving sugar to people who don't need it, or saline to people who need sugar, when people are working in the middle of the night, tired, otherwise subject to potential error.
I thought we tossed this back to you guys. Dr. Haas, you brought it up last month about maybe keeping it at 1,000 bag or rolling it out all at once, so that if you're working a colony, you're not throwing epi into 250, but go over to Gildan, you're throwing epi in 1,000. I thought that's what he proposed last month when we were holding.
He did, as of right now, we're gonna stick with the, state formulary.
Can't hear you.
As of right now, the suggestion that came from the state was to stick with the formulary as it was designed through the Collaborative Protocol Committee, because counting drops from 1,000 bag was too complicated.
Lord help us. We're supposed to use the stupid dial flow, so there's no counting.
You're supposed to.
Yeah, right.
I can't tell you the last time I actually saw one in use though, Paul.
Well, correct.
Actually, I can. It was 6 months ago.
It's good.
About 6 months ago.
All right.
Okay. And validation of our concept of combined meetings is antibiotic use and DOH policy changes. I think we already discussed them. Any further discussion or any new business?
I had a question, please, for clarification on the protocols that we can use now. BiPAP, which was really exciting. We bought some more ventilators for our Mohawk ambulance. BiPAP, though, is a trade name. Are we still allowed to use BPAP or the NIV mode then in place of that? Because it says to use BiPAP again.
I think it's written as any non-invasive. But yes,
Okay.
BiPAP is a trade name for an individual unit, but multiple vents can do bi-level ventilation.
Right, but in the protocol, from what I just looked at to clarify, it said BiPAP, and I wanted to make sure that I was going out to buy the Philips or Respironics BiPAP machine.
Yes, it would have never been written for a specific.
I didn't think so. So maybe it was just a typo, if you will.
If we have to bring that to the collaborative, that's like saying you can only buy Tylenol, branded Tylenol.
Heidi, what protocol is that, please?
Anywhere where we could use CPAP, Beth? We can now use BiPAP, if you will. So the respiratory. CHF.
Yeah, I think it's respiratory and I think it's actually the airway management protocol, but we can go back and check that, find out what it is, and ask for a clarification of that. But in the meantime, for purposes of this, there was no intention of endorsing any specific product anywhere within the protocol.
I didn't think so.
Most people don't even know there's a plan.
Yeah, I mean, everybody calls it black pepper.
Yeah, the intention was bi-level positive, positive pressure, non-invasive positive pressure. Yeah.
That's more of a mouthful.
Yes, stick with black pepper.
Okay.
So one of the things I sent out to everybody, and there were 3 interesting studies that that came out relatively recently that got a lot of attention at EMS World, and have gotten some discussion at ASAP as well. The first, Rob seems to think I should be on a chair. The first is a study that came out of Oregon Health Sciences University, looking at a little less than 300 patients who underwent defibrillation. They found almost a 2.5 times increased conversion from ventricular fibrillation when pads were placed anterior or posterior rather than anterolateral for purposes of defibrillation. Obviously, this is a small study, but that is a pretty significant signal from a small study. So my suggestion to agencies would be that they ask their providers to document the location of the pad placement as part of the process of defibrillation and the documentation of defibrillation. It's not yet part of any CARES documentation. I think it actually would be extremely helpful for us to follow moving forward, particularly since now we also have the possibility of going back to double sequential defibrillation and changing pad placement through medical control. So this is just one more thing to see that we can optimize the ability for us to convert ventricular fibrillation. We sent that out to everybody. If you didn't get the article or the link to the article, which was in JAMA Open, you can drop Tim a note, drop me a note, and we will get you that link. Because it was actually very, very interesting work. The other 2 papers that came out recently, and I don't think that either one is enough of a signal for us to change practice. One was a study of a significant number of cardiac arrests from the state of California, where the patients were also received naloxone in many cases. The patients who received naloxone, even for non-shockable rhythms, seemed to do better in terms of outcomes. There are so many confounders in this study that it's extremely challenging to start to tease out the answers here, but it was a very interesting signal. And I do know that my practice will be that I will no longer reprimand people who give naloxone in cardiac arrest, but I'm not yet to the point where I want to give it to everybody in cardiac arrest. But I do recommend that you seek out that paper and read it for yourself. And the third one that was equally fascinating is a study that involved intramuscular epinephrine and cardiac arrest, where giving a large dose of intramuscular epinephrine, so 5 milligrams of intramuscular adrenaline, led to increased return to spontaneous circulation in cardiac arrest. We don't carry enough 1 to 1,000 epinephrine to do that. It certainly is a fascinating change. We're not going back to the 30 ml vials, as Dean is suggesting, but it is an extremely interesting signal one more time, because we've always said intramuscular meds aren't going to be much use in cardiac arrest because there's no perfusion. But here we have a signal pointing to things that are just a little bit different. So, you know, keep an eye on the science. There's some really neat stuff going on out there. Really smart people working on some of these things. Making sure that we've got our CARES data as accurate as possible is going to be really important for us moving forward in terms of making interventions and creating changes for protocols in New York. And the better we can be at maintaining our data and being able to access that data, the better we'll be able to improve care for our patients. So thank you all.
Okay. Any new business? Okay, before everybody gets excited about getting out of here, we are probably at least 2 years behind on elections for chair and vice chair. According to our bylaws, the election should be done the meeting preceding the last meeting of the year, which would be today. First question is, are there any nominations for chair or vice chair?
Rob, I nominate Rob McHugh for chair. I second it.
I'm hearing silence. Okay. If there's no other nominees, any chairs or what's that? Okay, Mike will take over for now. It's kind of hard for me to do.
So it's not fair to ask Rob to preside over the election where he is actually one of the candidates. Is there anybody else that would like to throw their hat in the ring to be chair of the Remac? Sam, was that a hand I saw go up? No, that's.
No, I support Rob for another term.
You don't have to bring cookies. Don't let that dissuade you.
That's an
Okay.
impeachable offense.
If there are no other nominations for chair, can I see on camera a show of hands of people who are voting for Rob for, oh, that's true, or in person?
Do you need to close nominations first, Mike? Technically?
I believe Sam is absolutely correct. We will close nominations.
Yes, yes,
Do you
sir.
need a vote for that first?
No,
Okay.
we don't.
Yeah, guys, there's two more times. Go. Yeah.
So I asked twice, you asked once.
You asked twice, I asked once. At the end of the day, we do this all by consensus anyway. And there are no other nominations, right? Okay. All show of hands, everybody voting for Rob for chair. Anybody opposed? All right, show of yellow thumbs, I guess we've got two. All right. No opposition. Congratulations, Rob. You are
Chair
once
again.
again chair. All right.
Yeah.
There's
All
a
right.
sword that we
You
followed
may
on.
now go ahead and
Okay.
run the election for vice chair.
Now, for vice chair, currently occupied by Heidi Cordy. Do I have any nominations?
I would renominate Heidi for vice chair.
Okay,
Yeah, she's out here.
She's on.
she's on.
Does
So
Heidi
that's,
accept it?
does Heidi have a choice of accepting it? Okay. Do we have any other nominations for vice chair?
I don't know if I'm allowed to make a nomination, but as the Aram's representative to this council, I'd like to nominate Dave Afianco to represent the Aram side as well.
Dave Afianco now requires some Haldol.
I see he's on. I don't know if he
Yes.
wants to go for it.
Vice chair.
Vice chair. Run the meetings when Rob isn't here.
No. He can decline it.
He has respectfully declined.
Bummer.
Give him 2 years.
I think there was some influence there.
No. So one more time, any other nominations? Okay, Heidi, you're on the spot. Do you accept?
I'm blessed, thank you.
Okay, so nominations are closed. Can I have a vote for Heidi Cordy as vice chair? 1, 2. I have hands. Is anyone voting against? No one. Okay, Heidi, congratulations. The bylaws will state you have to bring the cookies.
I'll even bake them.
All right.
Better than we're doing.
While you were talking about pilots.
Yes, so we are looking at redoing the bylaws. We've made a quick pass through with some changes, more aligned to how we function versus how we were functioning 7 years ago. A part of that is having a line in there that all of Aram's members are members of us, and hopefully vice versa. If there's anyone else who would like to have direct input on the formative phase of this, please get back to me or Mike.
So time frame for that will be draft to this body in December for a vote in February.
So that was draft for the December's
Yeah,
meeting to
won't be
vote in
January.
February. Because we never meet in January. Okay.
No, it has to age 2 consecutive Remac meetings.
Okay.
So it will
So
be
April.
January, February, we will vote on these changes in April.
Yeah, so sorry, it's two meetings, so April would be when we would vote on it. Okay. Any further discussion? Any, yep, Steve? Steve, is that a hand up for voting or a hand up for I want to talk? Should have taken an intermission. Okay, so I'm gonna assume the hand up is a mistake then, Steve. Okay. Can I get a motion to adjourn? And we'll see you all in December. I have motions in the room, which you could be part of. Gingerbread and cookies in December, maybe hot chocolate too. I'm gonna up the game. Not that far. Okay. Everybody having,
Are we moving the December meeting? Because right now on December 4th, it's the same time as CMAX EMSCO.
then yes, we probably are.
So we move it to
Typically,
Wednesday,
we would go to the next Wednesday.
Wednesday, the 11th.
Yep. Yeah, so we
Dr. McHugh?
Yes. Go ahead.
Can you hear me now?
Yes.
Sorry about that. I was having a microphone difficulty. I had to step away during the portion of the conversation relative to the bags, and I believe it was epinephrine drip that you were discussing. Where was that left off?
That was continue with the current state protocol.
The way that it's written now in the 250 bag?
Yes.
Okay. Thank you.
I have it as December 11th.
We already did that.
Yeah, we already did it. Okay.
So Rob, just to clarify, the next meeting will be December 11th.
Yes.
Okay.
And Heidi, make sure you're there because I'll need you to finish it up.
I will let the person who makes our schedule know. And bring the cookies, I know.
Well, it's a little early, but everyone enjoy your Thanksgiving and Halloween before then. Yeah.
You too. Take care.
So long.